In today's video, we are going over a masterclass on patellar tendinopathy. In the first video, we go over what PTs need to know about this common condition. In the second part, we go over all things treatment. What are the best evidence-based treatments for folks that have patellar tendinopathy? Is it isometrics, isotonics, heavy slow loads, progressive tendon loading? We break all this down for you. So buckle up. This is going to be a meaty one. In today's video, we're going over what physical therapists need to know about patellar and quadriceps tendinopathy.
So we have tendinitis, tendinosis, tendinopathy, and tenodesis. So yeah, they all sound very similar. In terms of patellar and quadriceps tendinopathy, the research has kind of shifted to that term because tendinitis suggests that there's an active inflammatory process, which there may be. I guess it seems like we've kind of shifted back and forth on this a little bit. But I think the reason they really started driving this home was because the primary treatment is no longer rest and NSAIDs and that type of thing. It's not primarily an inflammatory condition. So when you see itis, tendinitis, we're thinking an inflammation of the tendon. A tendinosis is a more degeneration of the tendon. So if you look at it under imaging, you see changes to the tendon, and it shows that it's degenerating a little bit. Tendinopathy, as I said, this is the clinical term that we're using for this type of tendon pain. So that's the key thing is it's a clinical presentation of pain in a tendon, resulting in dysfunction. And that could be with or without structural changes. So when you see it in the clinic, that's what we're calling it. And then more unrelated, but the tenodesis is a surgical treatment option where they change the site of the tendon from one part of a bone to another. So I thought that would be helpful just to clear the air here of these different terms because they all sound so familiar.
Pardon the interruption, but I have something that's going to change your life. It's $1 million. No, it's not. But it's an evidence-based guide to patellar tendinopathy. Staying on top of literature is hard. It never feels good to have a patient in front of you with a specific condition and you haven't read through the research recently. Well, this bad boy is going to help you out. It is an evidence-based cheat sheet for patellar tendinopathy, and my promise to you is I'm going to catch you up to date with the literature on patellar tendinopathy under 10 minutes. We go over definitions, anatomy and biomechanics, differential diagnosis, risk factors, prevalence, clinical presentation, recurrence rates, how to diagnose this condition, and all the best treatments for this common problem. Best of all, it's 100% free, so go ahead and click on that link in the show notes in the description and get your cheat sheet on how to best treat patellar tendinopathy. Now back to your video. Like that, Kevin. It's good to just kind of get a little refresher on that. Yeah, it seems like over the course of time, we now know that patellar tendinopathy is not necessarily an itis, although I'm sure we'll talk about this a little bit later. There's a little bit of inflammation there, but it's not quite the same as a full-blown tendinitis. That being said, usually with the tenodesis, you see that in the biceps tendon, not necessarily in the patellar tendon, but good to know the definitions. Unless you're doing patellar tendon tenodesis in the clinic somewhere that I don't know about.
All right, so a little more background here just on the patellar and quadriceps tendinopathy is that they can be debilitating and they're very, very common. Like if you work in an outpatient orthopedic setting or a sports setting, this is something you're definitely going to see, both of these things. So just in terms of prevalence a little bit, one prospective study which looked at elite athletes competing in soccer, long distance running, volleyball, orienteering. I think that's Dan's favorite sport. Basketball and ice hockey noted that 50% of the athletes with patellar tendinopathy were forced to retire from sport. And when asked why, they noted that their patellar tendon pain was one of the reasons that they retired. So, just interesting. I think when you are competing at a high level, this is something that we'll see pretty frequently. We'll touch on prevalence a little more coming up, but and then in terms of pain location, so the patellar tendon pain location, you kind of see it in, I guess, a couple places, but most commonly is the inferior pole of the patella. So if you kind of palpate the patella and you work your way down to the very bottom portion, that inferior pole, and you poke it pretty hard, a lot of people will have symptoms with that and they'll complain of pain there. You can also have pain a little bit lower at the kind of tibial tuberosity, for the tendon inserts, but not as common, only 5 to 10%. And then clinically, I've seen a lot of kind of mid-substance pain as well. Like if you're just squeezing the middle part of the tendon, that can be painful. but inferior pole for sure seems to be the most common location of pain. And then in terms of that quad tendon pain location, where on the upper side of the patella, so the superior border, and you'll see that most commonly as the pain location for the quad tendinopathy.
Just a little anecdote. I tend to see a lot of quad tendinopathy in my orienteering sporting population. Actually, I have no idea what orienteering is, but I do actually see a little bit more quad tendinopathy than I thought I would. And I don't know if that's because I see more lifters. I actually tend to see probably more tendinopathy of the quad tendon than the patellar tendon. I think that's because of the population. If I was working with volleyball players or basketball, I bet you it'd be more patellar tendinopathy. I have no idea. Just thought it was a little interesting anecdote that I tend to see that a little bit more.
All right. How do we diagnose this thing? So for patellar tendinopathy, I think it's relatively simple. There are some other things we'll talk about differential diagnosis, but there's localized tendon pain. And as I said on that previous slide there, usually on the inferior pole of the patella. So the pain, it's not a very diffuse pain where you're getting pain all over the place, like patellofemoral pain can be. It's really right on the patellar tendon and that inferior pole. You'll hear, or the patient will say, that pain increases with movements that put increased demand on the knee extensors. So when you're really loading the quads, we tend to see more pain with those types of activities. And activities that load the tendon at a very high strain rate. So I thought this was interesting that a body weight squat imparts a load of 4.8 times body weight. So just something to consider. The strain rate of that is 1 to 2 body weights per second. Kind of hard to wrap your head around this, but just compare that to spiking in volleyball. It imparts a very similar load of 5.2 times body weight, but it does it at a strain rate of 40 body weights per second. So it's really that high strain rate you could think of as the speed of the movement. And that's really what's going to load that patellar tendon more. So you might hear, someone say they have some patellar tendon pain with squatting, but more commonly it's going to be those high strain rate things. Someone that is jumping explosively, more likely to be a source of pain. They might describe a warm-up sensation. So a lot of times the person will say, when I'm starting out my activity, a basketball player, I'm in the layup line to warm up. It's pretty sore, but as the game progresses, it gets a little bit better. And then they may show that 24-hour period where it's actually worse if this is kind of reactive. But you want to ask about, does it warm up? Kind of helps you rule in a tendinopathy. One test you'll see a lot that I think is very easy to do and seems pretty decent. I didn't find any sensitivity or specificity with it, but just doing like a decline squat test. So keep the torso really upright, squat down. Does that bother the tendon? And then some jumping with that, maybe to see if that bothers the tendon. And then imaging, probably not something we need to do to diagnose. There may be some degeneration showing up on the imaging. We do find that if you don't have tendon pain, but you do have tendon degeneration or tendinosis, that you do have an increased risk of developing tendinopathy. But it's not something we're going to use diagnostically. So just keep that in mind.
I think what you said about the strain rate was really important. And yeah, those numbers are tough. And I kind of struggle in terms of using the word strain or stress or load, what you're actually doing to the tendon. And it gets a little bit complex. But I think the takeaway here is that the faster you move, generally speaking, this is going to stress patellar tendinopathy, has a likelihood of creating it and or exacerbating it. And I think where it's important from a treatment perspective, and we'll get to this a bit later, is if you do an isometric, there's obviously no movement. And this is usually pretty well tolerated. And if you move slowly, think of a heavy, slow load, usually that's tolerated a little bit more than a faster movement speed. And then think about plyometrics. Usually that comes towards the end stages of rehab. So what we're trying to do is dose exercises starting with slow or no movement and then progressing to faster movement for this exact reason.
All right. And then in terms of diagnosing quad tendinopathy, Dan, I think your input here would be good too, because you see this, like you said, pretty often, but you'll get a localized pain, like I was saying, at the superior border of the patella, so just above the kneecap. And it also is going to show increased pain with movements that increase demand of the knee extensors. So kind of those quad dominant movements that we might see in the gym. And similarly to patellar tendinopathy, pain increases with activities that load the tendon at that high strain rate. So that very high load, high speed. Again, it will be tender to palpation, similar to the patellar tendinopathy. And as most tendons do, they might demonstrate that warm-up effect. So something else you might want to listen for is, does that seem to be happening?
I think you nailed it. I find that it's very similar to patellar tendinopathy. If you do have a lifter, usually it hurts with kind of squatty movements or some of the Olympic lifts. So as you descend into a squat, the knee starts to hurt. It kind of looks and seems a bit like patellofemoral pain, whereas where you descend a little bit deeper or when you add more load, it tends to hurt a bit more. And the pain tends to be just above the kneecap. So initially, people say kind of this anterior knee pain. They kind of put their hand on their kneecap, and you start thinking, this seems like patellofemoral pain. But if you start poking a little bit more, you're like, oh, this actually seems to be a bit above the patella. And in terms of kind of differential diagnosis and then treatment, usually, at least for patellofemoral pain, we can start with a little bit more hip dominant movement. But for some of these quad tendinopathies, I want to start probably thinking about loading the quad earlier in rehab, although I bet you hip dominant movements are probably going to be helpful for quad tendinopathy too. I just don't know that the literature is robust as with the patellofemoral research, right?
All right. And then just, when we're trying to diagnose this thing, there are other diagnoses I think we want to rule out. So anterior knee pain, there are a few things we could be thinking about. And patellofemoral pain is definitely one. So you could go back and listen to our episode on that we did pretty recently. I think that was a couple good episodes.
Banger.
Osgood Schlatters, something that you'll see pretty often in the younger population. So this is a pain of the growth plate where you have your tibia tubercle, and it's kind of that bump on the proximal tibia where the tendon inserts. So if you have someone who's above, probably the age of 15 or 16, it's kind of less likely that this will be what's going on. But something to keep in mind in younger folks, because it can present very similarly and be pretty painful. Very similarly, Sinding, Larson, Johansson. So this is the same type of growth plate issue, but this is at the inferior pole of the patella. So just keep that in mind as well. If you see a younger population, this could be the source of their pain, and you're going to manage it pretty similarly, but just know that could be a little bit different, what's going on. And anytime we have anterior knee pain, we want to check for swelling and make sure that maybe they don't have some meniscus or ligament involvement, something intra-articular. With those, you're probably going to hear about a traumatic incident sometimes causing their pain. You might see some swelling and that type of thing. In runners or, other sports where you're doing a lot of impacts, you want to make sure you're ruling out a femoral bone stress injury. I think this will be relatively easy because it's not going to be pain, right by the kneecap, the inferior pole. So you've really used the location to differentiate that. And then Hoffa's fat pad syndrome is another anterior knee pain structure that can give you that anterior knee pain that you want to be on the lookout for. So that will present relatively similar, but with that, they tend to get pain with kind of forcible end range knee extension. And the mechanism's a little different, but make sure you're kind of considering some of those things when you're going through your eval. With the patellar tendinopathy, it's really going to be pain with loading. They're not going to have swelling. They don't tend to have pain at rest. This is something that hurts with activity. They won't have joint line tenderness. They may or may not have joint laxity, but that won't be caused by the patellar tendinopathy. So, keep those things in mind. I think it's fun to practice ruling those out and feel confident in the diagnosis.
All right, and I think that what you had just said about the progressive loading, one of the things I like to do, which I think is beneficial, is that you can do some hopping. So some double-legged hops, maybe some pogo jumps, starting kind of lower jumps, work your way to higher double-legged jumps. And what you should find is that pain goes up as that intensity goes up. You can try some lower level single-legged hopping, which again is a little tougher than double leg. Then you go to a higher single-legged hop, and you should really just find that pain gets worse over the course of time. For something like a bone stress injury, you may find that the pain is kind of severe with everything and doesn't change too much. Although I think that the more strain you throw on anything, it's probably going to be more painful if you do it at a higher intensity. But that is one of the hallmarks of a patellar tendinopathy. It's just that the more intense the exercise, usually the more pain that you get.
All right, now a little more on incidence and prevalence. And I thought these studies here were pretty cool. So these were out of, I believe it was Norway for one and the Netherlands for the other. I forget which one was which in terms of elite and non-elite athletes, because they were looking at, one was looking at elite, one was non-elite. And they were looking at the rate of symptomatic patellar tendinopathy in these two groups. I think in the elite group, it was about 50 or so athletes. In the non-elite group, it was somewhere in the 800s, so a little bit better number. And really the point here, I'm not going to go through each and every single one, but what you'll see if you're watching this is that for all the elite athletes, they have significantly higher rates of symptomatic patellar tendinopathy than non-elite athletes. And I thought that was interesting because I think this shows that the higher you're loading the patellar tendon with the more skilled and higher level competition, is you're loading the tendon so much more, you're more likely to get patellar tendinopathy. So again, I won't read through every single one, but I think a quick example is we see in professional volleyball players in this group, 45% of them had symptoms of patellar tendinopathy versus the non-elite cohort only had 14.4% with symptomatic patellar tendinopathy. So, that's like 4-ish times higher in the group who is elite, right? So we see that as you're training more, you're getting more and more jumping cycles, you're probably more likely to get this thing. And then we do see, this is kind of interesting, this study floats around quite a bit if you look at patellar tendinopathy research, but there was a study showing that up to 90% of NBA players show tendon changes on imaging. So that sport, obviously, you're very explosively running, cutting, jumping, really loading the tendon at those high strain rates. And you get degenerative changes to the tendon. And like we said earlier, that doesn't mean you have symptoms, but it does definitely, it seems to predispose you to getting patellar tendinopathy. You're more likely to get it. So I think, takeaway is that those more elite athletes training at a very high level, they're loading the tendon so much more. They're probably at higher risk of getting it. We don't see this so much in non-elite athletes. I mean, we do, but I think the lower the level of competition, probably the less likely you're going to see this versus that higher level.
And not to get too much on a soapbox, but I think Kevin and I were just talking about this last night. In the social media world, you have a lot of prominent folks saying that imaging doesn't matter. And I think for a lot of different pathologies, maybe has some truth to it. But I think that in studies like this, and in this population, up to 90% of those basketball players are going to have tendon changes via MRI, and a third of them are going to have symptoms associated with it. So it does seem as though having tendinopathy can correlate with eventually having pain. And you're certainly seeing that in this population. So I do feel that imaging is warranted in some folks, right? So because people have tendinopathy that can be asymptomatic, again, doesn't necessarily mean that it can't be symptomatic. And I think the problem is that we may tell our patients it doesn't matter, when in reality, in this case, it really probably does. And it will potentially dictate your treatments, right? If they find some calcific tendinopathy, maybe you're thinking more about 10X. Maybe we're starting to think more extracorporeal shockwave therapy. It does help to guide your clinical reasoning. So we could talk about that all day. I just wanted to note that and show how it's another example where imaging is probably relevant.
All right. And then in terms of risk factors for patellar and quad tendinopathy, we do see this is one condition where males tend to get these types of tendon pains a little more frequently than females do. And there was one study that had about 2,200 athletes, and they were made up of 25% male and 13% female. So those were the numbers of people who had tendinopathy. So about double for men in that study. And this was confirmed by 2 other studies, which showed that men suffer from patellar tendinopathy at rates about double that of women. And what I saw for kind of the author's speculation is that perhaps it's just that men's quads tend to be a little bit stronger and they're maybe loading at a higher strain rate. So maybe that's why we see that they're a little bit more likely to get these types of tendinopathies. Another risk factor is training volume. So there was this study that showed that participation in sports is a risk factor for who's going to develop tendinopathy. And I think that's totally true. We don't really see sedentary folks getting tendinopathies too often unless there maybe is some systemic thing going on. And then elite athletes who train over 12 hours per week had higher rates of patellar tendinopathy than non-elite athletes who train 4 to 5 hours per week. So, just all those exposures, this is definitely an injury that you see more commonly with those exposure hours going up. And then there was one other study that was looking at the amount of jumps performed by volleyball players throughout the course of a season. And the team was practicing a similar volume of hours, right? So they look at how many hours are they practicing in the season, and folks on the team, obviously they're training together, had similar amount of time practicing. But when they actually look at the number of jumps of the people who are getting tendinopathy and those who aren't, there was a statistically higher jump volume in those getting it. So just another thing to consider, right? We see high workloads, higher risk of this type of injury. So pretty interesting.
A couple things to add. So for one, it makes total sense. The reason why Kevin gets injured frequently is probably because he's too strong.
Too strong, especially my quads.
Very strong quads, lots and lots of knee pain. Secondarily, you kind of noted something about this, but patellar tendinopathy is interesting to me because if you look at other forms of tendinopathy, so I think rotator cuff tendinopathy is probably the biggest example, but also Achilles tendinopathy, the rates tend to go up as you age. So as you get older, more and more of this pathology starts to occur. Patellar tendinopathy is a little weird. There's kind of like a sweet spot of when patellar tendinopathy occurs. And once you get past that sweet spot, so maybe somewhere between the ages of like 15 and 30, the prevalence goes down. And it maybe speaks to the specific nature of maybe jumping in certain sports. It creates more patellar tendon issue, whereas just living life in general seems to be a little more stressful on the rotator cuff. Just speculation, but that's something you probably will see. More folks that are younger having more patellar tendinopathy, and then they kind of almost age out of it. Although this is anecdote, I still continue to see it with older adults. It's just that that's generally when they've had it in the past. It tends to kind of pop up again. But that's an anecdote, just something I've noticed.
Yeah, and then a little bit more about risk factors. So we do see that sometimes in folks who are on certain medications may be at higher risk of developing tendinopathies. So I think like Dan just said, totally in the younger population, you probably see people doing more activity than they do when they're older, more likely to get this thing. But in some older folks who may be on a statin to help lower cholesterol, we do see statins might predispose people to developing tendinopathies of all types, not just patellar and quad. And we do see a little bit of a correlation between obesity and developing this type of tendinopathy. So maybe something to consider outside of the realm of the elite athletes. And then just a little quote that I thought was interesting from a study looking at tendinosis, so the changes in the tendon. And the authors examined 54 professional soccer players before and after a season using ultrasonography to look at the tendons. And patients with asymptomatic tendon degeneration, they were at significantly higher risk of developing a symptomatic tendinopathy. So this just goes back to what we were saying a couple slides ago, and I think Dan had made a good point. Sometimes the imaging does matter. And in this case, maybe if we, hypothetically just thinking through here, if we see someone and you're in this setting where you really have access to this imaging and someone has, a pretty significant change in their tendon, maybe you're a little more cautious about how you're training going into the season. Maybe you're doing a little bit less volume of jumping because we know that's something that can be problematic for folks and cause them to develop patellar tendinopathy. So we can use the knowledge about the imaging to modify their training programs So hopefully they can make it through a full season without getting these symptoms and having to lose time on the field. And then very similarly, another study showed that 141 asymptomatic athletes at the beginning of a season who had hypoechoic, I think that's how you say that, areas of neovascularization represented a risk factor for developing patellar tendinopathy. We know that when you have new vascular tissue in an area of a tendon, that is one of the changes we see in tendinosis. We see more blood vessels, more nerves. So this is showing a very similar thing. When we see these tendon changes, a lot of times these folks are the ones who are at higher risk of developing tendon pain throughout the course of a season. So just again, cases where imaging may matter, and maybe there's a way we can modify training programs to stay on the field or, staying able to play.
Kevin, I'm going to have to agree to disagree here. I don't think imaging matters ever. Okay. Kidding, right? But obviously you can see where this is an instance, right, where it is important. And I talked to Rob Mansky about this like a week or so ago. And one of the things they do is they'll ultrasound, let's say, a rotator cuff and see it's progressing over the course of time. And then you can use the information to decide whether or not someone needs surgery. I think it's very reasonable to use something like ultrasound, which is a bit cheaper than an MRI, for your athletes, let's say in their off season, and then try to track these changes over time. And then you can probably change their training volumes, loads, so on and so forth to help to minimize that risk. I mean, in NBA, you have these athletes getting paid millions of dollars. An ultrasound is not that expensive in the grand scheme of things, but missing multiple games is. So I can see, at least in that situation, where it's really important. For the average person, do they need this? Maybe not. But having an ultrasound would be kind of cool if we had in a clinic. It's not that expensive or doesn't take too much time. It might be worthwhile to utilize that diagnostically if you have access to it. Hey there, you little learner. Do you like this content and want to go a little deeper with that learning? You should join us with our online community, Insiders Academy. It's our premium subscription membership to help you become a better coach and clinician. We do a lot of good stuff at Insiders. We fill in those gaps in knowledge that school didn't teach you. We go over things like exercise technique and prescription, programming, periodization, strength conditioning principles, and advanced rehab. Let's get you proficient there. We also help to keep you up to date on the latest medical literature, even if you don't have time. And we do this with cheat sheets. And these are PDF downloads that catch you up to date on a given topic in under 10 minutes. And we've got a lot of them, over 50, and we're constantly updating them and adding new ones. It's pretty much the exact same thing as downloading all of our knowledge directly into your own brain. We also keep you up to date with our master courses. We cover pathologies in depth so you know exactly how to diagnose and treat patients with these issues. And we're really thorough, going over prevalence and prognosis, risk factors, anatomy, history, clinical presentation, diagnosis, differential diagnosis, patient education, and exercise prescription, as well as manual therapies. We have a whole bunch of master courses, and we're always updating and adding new ones. Some of the big dogs are rotator cuff related pain, knee osteoarthritis, shoulder instability, femoral acetabular impingement syndrome, SLAP pathology, cervical radiculopathy, lateral ankle sprains, and radicular low back pain. Who doesn't love some searing back pain going down their leg? We also include case studies with every one of our courses. This way, you can see exactly how we diagnose and treat. Each master course comes with in-depth protocols, both non-op and post-op. This way, you know the exact exercise we'd like to use with videos of all movements, how many sets, how many reps, how do the exercises progress over the course of time, what are the relevant manual therapies when they're indicated, and exactly what you should educate your patient about. Hey, are you a physical therapist, athletic trainer, or physical therapy assistant and looking for some CEUs? Well, we got you covered, and you can even earn CEUs for watching the content you're watching right now. Finish up the master course, take the exam, get the CEUs. Easy peasy. With Insiders Academy, you also have community access. Basically, you can have all of your questions answered by me and the rest of our team at Fitness Pain Free. This way, as you go through the learning and you have a question, you'll get it answered. Best of all, you get started with Insiders Academy for just $1 for a week-long trial. After that, it's $25 per month. If you want to save 2 months, get them for free, then sign up for the yearly membership. I'm going to leave that link with a discount in the description below so you can check it out, and I'll see you there. Now, back to your learning.
All right. And then just a couple other risk factors without the most firm evidence, but I think just things to consider if we're looking at things maybe we can work on in the clinic a little bit. Some studies were showing a decrease in ankle dorsiflexion range of motion. And this makes sense to me intuitively, right? Like if you're one of Dan's weightlifters and you kind of lacking this motion, but you're doing a bunch of squatting, the motion has to come from somewhere, and you might pick up more motion at the knee. Perhaps that's loading the quad tendon a little bit more. Decreased quad and hamstring flexibility seems to be something you see off and on here. Greater jump training volume, greater counter movement jump height. So perhaps if you're just a better athlete jumping higher, we might be a little more risk. Number of volleyball sets played per week, again, relating to volume, and greater volume of training. So, yeah, I mean, we're seeing this in some papers, and then, I think it makes a lot of sense intuitively. So just things to consider. You might not see that in every single study, but important things that maybe we can try to modify and see how it helps the person in front of us.
Yeah, research like this, these are kind of the articles you can cherry pick to just like kind of push your confirmation bias. Like for me, ankle dorsiflexion, weightlifting seems to be really important and prominent. But what I will say is that knowing that this is mixed evidence has kind of led me down the pathway of chasing other interventions first. And these are more kind of ancillary things. Although from a critical reasoning perspective, I think you can easily, make the assumption that, all right, this person is an Olympic weightlifter. They're lacking ankle dorsiflexion. Having that would improve their lifts, obviously. Might also maybe reduce pain and maybe future problems. So it does make sense. But again, it's conflicting evidence. So it's important just keep that in mind.
All right. And then just kind of wrapping up with a little bit of the pathoetiology. So what's happening in the tendon. And just reading a bunch of different papers on this, one thing they were all saying is that we still don't really know what is changing in the tendon that's causing this pain. We do see some consistent things over time. But like, when does the tendon with a certain structure hurt and when does it not hurt? Kind of hard to say. So despite ongoing research, there's no consensus on tendon pathoetiology, and the complex relationship between tendon pathology, pain, and function is incompletely understood. That's just a quote from one of the papers I cited. But there are common things that we do see in these tendons and what can happen. So we do see kind of increased number of tenocytes, so those tendon cells in the tendon. The tenocytes are a little bit different in structure, so we see a change in the morphology. You'll see a disruption in the collagen fibers, increase in the non-collagenous matrix. Fatty infiltration is definitely something that seems to be in the research over and over. As I said a couple minutes ago, you might see a new growth of blood vessels and nerves in the area. There are some inflammatory mediators. So we talked about how, we got away from the term tendinitis because it's not primarily an inflammatory condition, but you do see some of those inflammatory cells in the area. And then these chronic painful tendons, sometimes you see more of a substance P, more glutamate receptors. So, there are some things that we can be on the lookout for. If we are doing any imaging of tendons or getting any imaging and we're getting these results, we can understand them. But, this will keep changing over time, I think, as we learn more and more about when does a pathological tendon become painful and how does that affect function. So be interesting to see how this progresses in the coming years. Yeah. And then, finally, just a little bit on prognosis. We can definitely treat these things successfully. So one thing that's important to understand is that recurrence rates are high. And then just a couple statistics here. So male athletes from 9 different sports were examined, and the mean duration of symptoms, pretty wild, 32 months plus or minus 25 months. So do the math there. That's a lot. And then another paper was showing that the range could be between 1 and 144 months. So basically, I think I just use this information to tell patients that depending on how long it's been going on, I think it kind of gives me some idea of how long this might take to calm down. So if you have someone with a 7-day history of tendon pain, hopefully you can make some changes and kind of nip this thing in the bud relatively quickly. But if you have someone coming in with patellar tendon pain who's had it off and on for years, it's unlikely it's going to go away in a week, right? They have to understand that even if you're doing all the right things, just be prepared that this could take several months, in some cases a year or more. But, as we'll talk about in the treatment podcast coming up, working through some pain is okay. And we have to be ready to educate our patients on that. So let them know that this will get better, but it can totally take some time, and we got to be prepared for that.
Yeah, Kevin, I think you kind of nailed it there. That patient education part is going to be really important. We don't want to tell folks that it's not going to get better quickly, because it certainly can. I think one of the issues with a lot of these athletes, they're playing sports. Oftentimes they're playing it year round. They don't have enough time to offload. These tendon problems oftentimes occur in the middle of a season. They finish up that season, maybe have a little bit of time to deload. They go right next to the next sports season, kind of pops back up again. So we're trying our best, obviously, to treat those, but maybe some education about how sports affects this and planning for the long term becomes important. And also probably important is that just giving that expectation, like this is probably going to pop up again in the future. We need to know how to handle it when it does. So let's try to be proactive as much as possible, but there's a dang good chance it's going to pop back again sometime in the future.
All right, so now you have all the background you need to treat this common condition. In the second half of this video, we're going to go over evidence-based treatments for patellar tendinopathy.
In today's video, we're going over evidence-based treatments for patellar and quadriceps tendinopathy. So what are we going over today? Let's summarize what you're going to learn. It's going to be great. So, of course, we're talking about treatments today, and we're going to give you an evidence summary. We're going to talk a little bit about patient education, what you should tell your patients. We're going to talk about exercise, mostly, and all different types. So eccentrics, isometrics, heavy, slow loads, blood flow restriction, progressive tendon loading, and movement modification. My gosh, there's so many different types of exercises. Which are the best? What should you use? What does evidence say? We'll talk a little bit about activity modification. So this is load management, obviously very popular right now, and as well as some jump retraining. We'll see if that's important or not. And we'll talk about some funky things you see sometimes. So if your patient's not getting better, or if you want to try to get them better faster, improve their outcomes, should you consider things like shockwave therapy, using a strap over the knee? How about surgery? Who should get surgery, and is surgery effective at all? You ready for this, Kevin?
Dude, I'm excited. Right now, all I do is surgery. So I like to do some other things for my patients.
Yeah, well, surgery is, good stuff. Just chop it off if it hurts, right?
Yep.
Sorry, that was a bad joke. All right. Let's start off with good old patient education. I think this is probably going to be the first thing that you talk to your patient about. And I've said this in prior podcasts, but I think patient education may be the most powerful thing you can do with your patients. So there is some research to help guide us. For a lot of these papers, they included patient education with exercises. So again, we're not really sure if it's the education that's most powerful or if it's the exercises, so on and so forth. But they're probably both important, right? And this is coming from a research paper called The Effectiveness of Progressive Tendon Loading Exercise Therapy in Patients with Patellar Tendinopathy. Breda was the lead author. And I think this was a great paper. We'll go over this a little bit later, but it's basically laid out in the way that most folks would do their physical therapy for patients that have patellar tendinopathy. And they utilize some patient education. And some of the things they went over were an explanation of the condition. Essentially, what is patellar tendinopathy? What is the expected management? So essentially, exercise is good for you, right? They talked about that positive influence of exercise therapy. They also talked about the positive effects of a gradual return to sports. So we don't want to go from 0 to hero, right? That big spike in training volume can cause problems. And they also used the pain monitoring model to figure out the progression of exercises. And it was kind of interesting because they were comparing this progressive tendon loading program with an eccentric program, which we have long considered a gold standard, although in more recent years, we know that eccentrics are not necessarily a gold standard. A lot of different things work well. And essentially, they were allowing 3 out of 10 or less pain during exercises, whereas in the eccentric group, they actually allowed 5 out of 10. So allowing more pain, maybe not beneficial, who knows, but I'll give you the results of that later. But just basically telling patients what's okay and what is not okay is important. So first we'll go over exercise. I think it's important to understand that all forms of exercise are beneficial, right? And this is coming from an article in 2018 where they're basically trying to figure out which types of exercises are going to be best, right? And again, this is 4 or 6 years old at this point, so there's been some more research coming out. More recently, we'll talk about, but essentially you can use eccentrics, which is using the lowering portion only. So think about a squat, doing something like a single-legged squat on the way down and then a double-legged squat on the way up. So you're really overloading that lowering portion. So isotonics have also been shown to be helpful. So that's the addition of the concentric portion. So basically doing a squat and going up and down together. Heavy slow loads have also been shown to be effective. So basically that's using isotonics, but using a tempo, something like 4 seconds on the kind of raising phase, 4 seconds on the way down, and then progressively loading that from like a 12 rep max to a 6 rep max. It's also research show that isometrics are effective for tendon pain. So essentially doing something like an isometric knee extension against the wall. And they've been shown to be effective in the short and long term, although the research in the short term is a little bit more powerful, right? And we'll talk about that research in a little bit. But there's no gold standard really in terms of which treatments are best. You can probably use a variety of different types of exercise, and it can be effective. And what's kind of nice is that you can choose what's best for the patient in front of you. If you have an in-season basketball athlete, you're probably not going to do as much kind of heavy, fast loading with that person. Probably want to slow things down, maybe more isometrics, maybe more blood flow restriction training, be more beneficial for that person. If you give them like a heavy eccentric program, you might just make it worse, right? So we can choose what's best for the patient that's in front of us. Any thoughts on that, Kevin?
Yeah, I think that's one of the best parts, like you had just said, is that we have options. And I think that the way I've looked at it in the past is that all the options work. But I think what you've said is kind of what I find now is that there's probably something that works for everybody. But what works, for someone at one point in time is going to be different. So, I could have 3 people with patellar tendinopathy, and maybe one of them just seems to do really well with heavy, slow loading. And one of them does really well with eccentrics, and the other one is, so flared up, they're only tolerating isometrics. So, any of those options are fine, and you could play around with which one's going to work for the person in front of you. And I think it's good to know that most of these different loading protocols are going to be helpful. So, if you try one, don't freak out. And if it's not working, try one of the other ones. And some people really find that they like a certain protocol, right? So I have a guy who he loves loading the quad machine, and he loves doing it with heavy, slow tempo. And he just feels like that really gets his quad going. It doesn't bother his tendon at all. Versus we were trying like rear foot elevated split squat with the slow lowering. And when that was the back leg, it really just kind of flared it up. So you can get creative here and find what works best for the person in front of you, which is pretty cool.
Yeah, and we'll talk about another paper a bit later that kind of emphasized your point here. But essentially, we can use what we want. And if we use something the patient likes and enjoys, they're probably more likely to do it, probably have higher patient satisfaction and less pain. And all those things are a positive. So I would say that you can be a little bit more pointed, and you may actually have a better outcome simply because the patient's more likely to do it. They like it. They believe in it more. All those things can be really positive. All right, Kevin, how about heavy loads versus moderate load? I have heard that you need to load the tendon heavy in order to make a change. Is this true?
Dude, that's what I've been telling people. So let's see.
We'll see, man.
We'll see.
So this was an article, American Journal of Sports Medicine, 2021. They looked at that. So basically, folks with patellar tendinopathy, and they're given a protocol of heavier loading versus moderate loading. And this was 44 adults. Essentially, the heavy group was using 90% of the 1 rep max, which is indeed heavy. And the moderate group was using 55% of 1 rep max. And if you look at broadly through strength training literature, usually that number that people start on to start building strength is 60% or greater. So they're actually just below that. So I do think it was kind of a moderate load group. And the outcome measures they had were the VISA-P, pain scale. And they were also looking at pain during running, squats, playing sports. And they also had ultrasound findings, which are cool. They're just basically tracking the tendon to see if the changes are different from group to group over the course of time. Lo and behold, what do you think they found there, Kevin?
I can't wait to hear.
Same outcome and both beneficial. Two things. I think you see this in other literature as well. So the rotator cuff is one of those. My criticism for those studies are that usually rotator cuff folks are sedentary, right? So it might not matter. They're not trying to get back to anything heavy. But for folks that have patellar tendinopathy, they're usually trying to get back to basketball, volleyball, so on and so forth. So I would think heavier loading would be more important to make that tendon more robust. This study didn't show that. So I think that's just important to keep in mind, is that there's this idea floats around, you need heavy loads to make a change, and it's going to be a superior outcome. At least this study didn't show that. Obviously, it's only 44 people, one study, but you're starting to see this a little bit more across different tendon pathologies. So just an interesting thing to note. All right, Kevin, isometrics. Should we use isometrics? Yes or no?
Definitely should use them.
Definitely. All right. Well, let's delve into this literature, shall we? This study right here, I think, is what started off isometrics with a bang, especially in the patellar tendon. This was researched by Ebony Rio. The title of the article is Isometric Exercise Induces Analgesia and Reduces Inhibition in Patellar Tendinopathy. Very, very cool study. Essentially, they had a few volleyball players. It wasn't very many. I want to say it was like 6 or 7 volleyball players. And they basically had them do a single-legged step-down task and ask how much their pain was before and then after applying these isometrics immediately afterwards. And then after, I think they did 60 minutes afterwards, they kept on testing the step-down to see if the changes would stick around. They performed 5 sets of 45 seconds of an isometric knee extension. And they used 70% of the MVIC. So they put electrodes on the quad to see how much electrical activity was going through the quad, had them push to 70%. Obviously, you can't reproduce this easily in a clinic. I tell my patients just do 70% of their perceived max. And guess what they found in this study here, Kevin?
This finding is always fascinating to me. It's crazy.
Yeah, it's crazy. So essentially, the isometrics worked very, very well. On average, these folks had a 7 out of 10 pain with a step down. And after the intervention, they were 0.17 out of 10 pain. So less than a 1 out of 10, almost a 0 out of 10 pain-wise. And what's really cool is that this was maintained for 45 minutes. And in the isometrics group, they had the added benefit of reduced cortical inhibition. One of the things that happens in tendinopathies, and the way it was described to me, which makes a little bit of sense, is when you have tendinopathy that's symptomatic, it's kind of like you have a teenager learning to drive and have one foot on the gas pedal, one foot on the brake. They're essentially slamming the gas, slamming the brake, slamming the gas, slamming the brake. Kind of the same thing happens with a tendon with tendinopathy. And we believe this has to do somewhat with the reduced cortical inhibition. And the isometrics actually improve that better than just doing isotonics. Here's a little caveat. They also improved isotonics in this study. So essentially, they just did knee extensions. And they actually worked really well, just not quite as well as the isometrics. What I will say, we won't go into all this literature. A lot of folks have tried to reproduce the same exact study in multiple tendons across the body, and most have not been effective. So essentially, what they showed is that isometrics and isotonics were kind of equally effective in reducing pain, although Ebony Rio obviously found that the isometrics were a bit better. So you can probably use both for your patients. At the end of the day, use what works a bit better, right? You don't have to choose one or the other necessarily. You choose the one that works the best. What do you think, Kevin?
Yeah, I think just a couple quick points on the last slide. You talked about the heavy, slow resistance versus the moderate loads. So heavy loads versus moderate loads. And I kind of agree with you. I tend to be using heavier loads because it more closely aligns with my patient's goals, right? They have to lift heavy. But that is cool to know. I definitely wasn't aware of that. I've been using the reps in reserve type model where we're trying to get like 1 to 3 reps in reserve to, I thought, elicit tendon changes. But it is cool that they looked at the tendon with the ultrasound and there were no differences. So I think in terms of managing tendons, that continues to give us more flexibility with what we do with people. We can find what works best for the person in front of us. And if you do have someone who's sedentary, who's going to be a lot more comfortable lifting, 55% of their 1 rep max, then that's a great option. And then just in terms of the isometric study, I remember you saying that to me, maybe a year or so ago, is that even though those results were really impressive, right, it hasn't been replicated. And anecdotally, I would say I don't tend to get a huge benefit with isometrics with my patients. I don't find that I have a massive reduction in pain because I know we're going to get back to isotonic loading anyway. And I find that just with like a good warm up, the pain tends to be reduced a little bit. And like you said, sometimes with just knee extension, where you're actually moving in the knee extension machine, sometimes people have a reduction in pain. So because I don't utilize isometrics much in my own or my patients' training programs as an end goal. I don't tend to use it very often in rehab. That's just my personal treatment approach right now. But, I think if all else fails, it's something we could try. And there is at least this study with a pretty stellar cast of authors on that paper showing that it could be helpful for some people. But I haven't been using it a ton. And I find that if we're doing it for the pain anyway, there's other ways it seems like that pain can be reduced through different types of warm-ups. And that's just my anecdote there.
Yeah, that's my bias too. I think I may have even told you this as well, is that if I can skip the isometric stage, why wouldn't I? Because I'm getting closer back to the activities that the individual wants to, get back to. My bias has been a little bit challenged from the progressive tendon loading paper that we'll talk about in a minute. But yeah, my thought is like, hey, if we can get back to heavier loading more quickly, faster movements more quickly, why wouldn't we? That's closer to their goals, right? The other piece that is important to keep in mind is that as physical therapists, we're also thinking about other things besides just kind of pain and the outcome of getting back to sport, although that is usually the priority. We also want to try to improve their performance, improve their strength. If we're doing low loads, we know that's not going to be as good for improving strength, right? So if anything, I might choose that higher load if the patient tolerates it well. That's a big caveat because oftentimes they don't, because I know that's going to build their strength more, right? And anytime that I can hit 2 birds with 1 stone, I am a murderer of birds. I'm trying to improve someone's performance and I'm trying to reduce their pain at the same time, almost always. So in terms of moderate loads, hey, we'll use it if we need to, but otherwise I would probably rather go a little heavier.
Hey, pardon the interruption, but if you're liking this content, I think I have something else that you're going to love. It's a free mini course where we go over solving some of the biggest problems that physical therapists are facing today. So what are these problems? Number 1, failing reimbursement. Medicare reimbursement has dropped 10% over the past 10 years, despite inflation going up 32% in the same time period. Documentation and admin overload. Physical therapists are often spending significant time doing notes and communicating with insurance companies, and this is often unpaid. High productivity quotas. Failing reimbursement rates force physical therapists to see more and more patients. Burnout and poor work-life balance. High productivity demands and extra work drive burnout. Insurance-driven restrictions. Insurance companies often cut patients off before they're ready, like ACL reconstruction patients, or they won't cover insurance for certain populations. Let's say a very athletic individual. They don't care about your athlete getting back to Olympic weightlifting. Debt versus pay imbalance. The average student debt after graduation is $153,000, and our salaries are not matching this amount of debt. Lack of public awareness and referral dependence. Patients don't always choose PT first. They don't know our strengths as physical therapists, and they oftentimes will favor other healthcare providers. So how the heck do we solve this? We do this through a 6C process to help you start working towards that career of your dreams. And before we go into that, we got to figure out first, what do physical therapists want? So we want to be incredible clinicians. We want to be respected and valued. We often want to work with a specific population in a specific setting. We want to be able to practice the way we want to be able to practice. And generally, we want higher incomes. Now, given the current state of physical therapy, it makes a lot of sense that folks like you and I are upset. So in this mini course, we go over the 6C framework to get off the hamster wheel. It starts with clarity. What is the ideal patient that you want to work with? Next is connection. How do we become part of their community? Next is captivation. How can you help them with their specific problems? Next is competence. You have to learn how to treat these patients inside and out. Next is building confidence. That comes with time and reps, because perfect practice makes you perfect. And lastly, compensation. You want to get paid what you deserve. And this mini course will start you on your journey there. I help you to transform your career, start doing more of what you love and less of what you hate. This mini course is 100% free, and better yet, if you finish the course and then finish the quiz afterwards, which is nice and short, you can get 3.2 CEUs for physical therapists, physical therapy assistants, and athletic trainers. Again, it's 100% free. I'll leave a link in the description. Go ahead and click on that and download it, and I'll see you inside of the mini course. Now, back to your program.
What are your thoughts on killing birds? Any thoughts before we move on?
That got me pretty good, especially because I know your t-shirt of birds are really government spies. So government's going to be pretty mad. Keep killing birds, dude.
Yeah. So just so people know, no birds were killed in the making of this podcast. I'm actually a big bird fan. That's one of the reasons I know I'm getting older, is because I'm watching birds. I'll see like a hawk and everything stops. I'm like, whoa, did you see that hawk? I'm just enamored. So yeah, no birds were injured in the making of this podcast. Let's get on to the patellar tendon. So the next question that I had was, are isometrics good for longer term outcomes? Because we just showed they can be really beneficial in the short term. What about if we introduce some isometrics, do it for a few weeks? Does that actually help longer term with individuals with pain? And this was another study with Ebony Rio called Isometric Contractions Are More Analgesic Than Isotonic Contractions for Patellar Tendon Pain, an in-season randomized control trial. So they're looking at isometrics versus isotonics in season. They had volleyball and basketball players. Group 1 had 45-second isometric contractions, 60 degrees. Same basic study parameters for the most part as in the prior study. And group 2 just did 8 rep max knee extensions, 80% of 1 rep max. And they basically performed these 4 times a week for 4 weeks. And they showed that both were effective. However, the isometrics were more effective for pain relief, right? And personal bias, I don't know if this is the reason why. Essentially, they were doing this in season. And those tendons are taking a beating. And when we do kind of heavier knee extensions, maybe that's too much. I don't know. Isometrics might be that nice step back in season that allows you to progress a bit better. Again, this is Ebony Rio. I'm not sure why, but anytime she's on the paper, it seems like the isometrics do a little better than the isotonics. But at least in this study, that's what they showed. So interesting stuff. Anything else to add about the isometrics before we move on?
Yeah, I think, like you said, I'd like to see it replicated a little bit more, but if it helps and you're not getting those results with other things, it's definitely something to try. And, I think I'd probably do what they did in the study for a protocol, because if it worked there, you'd want to replicate that as best as you can. I just find that it even takes quite a bit of time to like set up and do. It's a lot of time. It's pretty boring. And I don't like doing isometrics, but again, it's a good option that we can try. And perhaps in season, like you said, their training volume might be so high that they're not tolerating lifting 4 days a week. And maybe this is something that allows them to keep playing. So, use the research and try it and see if you get, good results.
Well said there, Kevin. Next, blood flow restriction training. Do you think it's beneficial to restrict most of your blood flow to your legs exercise? Sounds crazy, but does that help folks with patellar tendinopathy, Kevin?
Yeah, I usually restrict 103%, but
so the blood kind of goes backwards, kind of thing.
Yeah, yep.
Tries to go to the legs and gets forcibly, I don't know, redirected 3% the other way, something like that.
Yeah, they're still trying to work out how that happens, but
good. All right, so blood flow restriction, is it beneficial for athletes in season? Well, we have a study here. So this was in Med Science Sports Exercise 2022. Low load blood flow restriction, high load resistance training induced comparable changes in patellar tendon properties. So essentially, I have a couple different articles here showing that BFR training is beneficial for patients that have patellar tendinopathy. First of which, Cuttaford in 2020, IGSPT, 2 in-season decathletes that had success with BFR. Sentner et al. In 2022. They looked at BFR versus regular loading 3 times a week, 14 weeks. And what they found essentially was that the mechanical tendon properties and strength changes were similar between groups. So both had a positive benefit, and the benefit was the same. And that was pretty cool. That was actually the first article I mentioned. I kind of threw a curveball there and screwed with the ordering there. But pretty cool, because what they're showing is that BFR is going to be equally beneficial for reducing pain, improving outcomes, right? Also improving strength, which is what we talked about before in terms of moderate versus high load, right? And they also found that mechanical tendon properties had a similar improvement. So again, that thought is you got to put high loads through a tendon to see those mechanical changes. Maybe not the case. And you can actually get it with closer to 20 to 30% of your 1 rep max if you use BFR. If you haven't worked with very many patellar tendon patients, usually these folks don't tolerate heavy loads, right? So all this fun stuff like, I don't know, single-legged heel taps, decline, slant board, squats, Heavy loading via leg press, split squats, step ups tend not to be tolerated very well, especially in the early stages of rehab, and particularly in in-season athletes, because we're already getting that patellar tendon hammered by sport. So blood flow restriction is really nice for these folks. And it seems like at the very least, it's giving very similar improvements in strength and performance, as well as those mechanical properties and pain, so on and so forth. And again, Burton et al. In 2022, basically their conclusion was BFR is encouraging, but we need more research, which is what every single research paper shows. But keep in mind, a lot of these studies are smaller sample sizes, not a lot of athletes. We probably do need more research. Can't hang our hats on just a couple studies. Any thoughts on that, Kevin? Do you use BFR much with your patients with patellar tendinopathy?
Yeah, totally. I think if someone's too irritated, they're in too much pain to tolerate what I usually use, which would be heavy, slow resistance training. I find that instead of going to isometrics, I tend to go to BFR. I guess it's just our patient population. They're used to training a lot and they want a kind of good workout. They want to feel like they did some work. And a lot of times you can do more simple movements at a lighter load with blood flow restriction. And they kind of get those benefits and they feel like they had a good training session without the tendon pain. So I guess the limitation there is that they need access to the cuffs, and it's not something they can usually do on their own. But it is a nice thing that they can do with you in the clinic. And it's definitely something I'll utilize for that first stage and then kind of progress as we can to more kind of regular lifting without the BFR.
Yeah, I think that's really smart. One of the biggest issues for athletes, we talk about this a lot, but these folks, their life oftentimes revolves around their sport. And once they can't play their sport, they have an identity crisis, right? And they're really having a tough time from a psychological standpoint. If you can put some BFR cuffs on them, have them do a whole bunch of exercises with minimal to no pain, have them feel like they're able to work out again, you get a huge psychological boost. And even if the outcome is going to be exactly the same as doing isometrics against the wall, athletes probably going to be pretty excited about what they're able to do and a little less down in the dumps afterwards. Again, total anecdote, but I see athletes that are super pumped after a BFR session, so excited they can actually train a little bit. So I think that's a really good point there, Kevin. All right, now the paper I've been talking about all episode, which I haven't really given you the deets yet, we're going to spill them right here. We're going to talk about progressive tendon loading. At least in my mind, this is the new kid on the block in terms of treatments for patellar tendinopathy. I feel like every few years we're changing our treatment for patellar tendinopathy. This is kind of the newer one. But I will say it was a great study and has changed the way I think about loading my patients with patellar tendinopathy. The study is called The Effectiveness of Progressive Tendon Loading Exercise Therapy in Patients with Patellar Tendinopathy, a randomized clinical trial, lead author Breda et al. And essentially they had 76 patients with patellar tendinopathy, mean age 24 years old, which is good if you're working with an athletic population. I think this kind of reflects that. Younger athletic folks. They were required to play sports at least 3 times per week to be included in the study. And what's kind of cool is that they had an average symptom duration of around 2 years, and 82% of the patients included in the study had failed prior treatment. So I think you're looking at pretty recalcitrant patients that have tried a lot of stuff that hasn't worked particularly well. So, spoiler alert, this type of loading was effective for these folks generally. So I think this is pretty interesting. Maybe it does show you that a more systematic approach might be better for these folks. But again, just kind of guessing. And they had an experimental group that used progressive tendon loading. We'll talk about what that is in a minute. And the control group used what is sometimes called the gold standard for treatment of tendinopathy, but they had an eccentric group, right? So their experimental group was the progressive tendon loading. Their control group was not like a sham or nothing. It was essentially another form of exercise we know that has been shown to be beneficial. So I wanted to see if the progressive tendon loading was better, right? And they had a 24-week follow-up essentially to see which group won. What do you think, Kevin? Before we move on, who won?
I'm going to go with progressive tendon loading.
Ooh, okay. We'll see. So let's take a look at these exercises. If you are listening to this, I apologize. Maybe head over to YouTube at some point so you can see what's going on here. But in the eccentric exercise group, they had a few stages, 3 of them. Essentially, stage 1 was a single leg decline squat. Kind of that classic exercise you see all the time for folks who have patellar tendinopathy. Stage 2, stage 1, they started with body weight and they started to work their way up with weight, okay, over the course of time. And then stage 2, they applied some sport-specific exercises. And lastly, return to sport. So it's not like they did only eccentrics. They kind of progressively loaded the patellar tendon with eccentrics. And then they went to sport-specific exercises. And then they went return to sport, right? In the progressive tendon loading group, they started stage 1 with isometrics. So they didn't move with isotonics in the early stages. They focused on isometrics. In stage 2, they did isotonics. And that's things like leg press, things like split squats, so on and so forth. They had a stage 3, which was energy storage or explosive exercises. So they threw in some plyometrics at the end of stage 1, stage 2. Stage 4, they did sport-specific exercises. And lastly, they returned to sports. So much more progressive in nature, starting with no movement and then kind of starting to load a little bit. And then they went into plyometrics. And lastly, they did their sport-specific exercises before returning to sports. Still going with progressive tendon loading?
Definitely.
It's confident. It's very confident. Yeah. All right, let's see the results. Outcomes. How about return to sport? And essentially, we're looking at return to sport at the pre-injury level, okay? So folks that felt they returned back to the sport at their pre-injury level, keep in mind, these guys have had pain for 2 years. So basically at the level they were prior to this injury starting. In the progressive tendon loading group, 43% of those athletes felt like they returned to sport at the pre-injury level, right? With the eccentric group, that was only 27%. So Kevin, you were right here. How about patient satisfaction? At 24 weeks, the progressive tendon loading, their outcome of a good satisfaction was 81%. For the eccentrics, it was actually 83%. So they were about the same from a satisfaction standpoint from the good standpoint. So essentially, I'm not really doing a good job describing this, but they'll ask the patients what their satisfaction level is at the end of going through the loading. Bad, good, and excellent. And what they found is about the same good response between the two groups. However, 38% of folks in the progressive tendon loading group had an excellent satisfaction, whereas this was only 10% in the eccentric group, right? From an outcome perspective standpoint, using the Visa P, progressive tendon loading was an 84, whereas the eccentrics on average was 75. And the last piece where progressive tendon loading was a bit better is that exercise were significantly less painful to perform in the patellar tendon loading group, with an average VAS scale of 2 out of 10 compared to 4 out of 10 in the eccentrics group. So felt a little bit better to do isometrics and slowly ramp up as opposed to jumping straight into very challenging patellar tendon exercises. So good job there, Kevin. I think overall you were right. Any thoughts on this paper?
Yeah, it's pretty cool. I think that's, kind of the way I think we tend to structure our training programs is thinking of what's the return to sport phase look like, and then work backwards from there. Like I had said, with the caveat of usually instead of isometrics, I'll start with blood flow restriction or something like that, and then progressing to the return to sport phase. Interesting though, either way you cut it, like the progressive tendon loading group, 24 weeks, I think it said 43% return to prior level. So I think that just goes back to, and it did say, right, these were patients who had failed other treatments. So these might be more intense patellar tendon pain. But I think it goes back to just educating our patients on realistic timelines, and that this could take a while, but hopefully you can get your patients back a little bit quicker. But I think it does show that if you did fail other treatments and you've been dealing with this for a long time, a quick fix is unlikely for this, and the patient shouldn't get discouraged by that. It's just, you got to keep training this over time. So that's kind of what I took away from that.
Yeah, for sure. Another takeaway for me is that maybe those isometrics are important. Maybe that's one of the reasons why people do better. Just to keep in mind, I'm going to link to this video in the show notes, but I basically did a video on a very new research study, which was trying to quantify strain through the patellar tendon with different rehab exercises. And they were looking at things like running, cutting, jumping, changing direction. And the exercise that put the most strain through the patellar tendon was a single-legged decline squat, right? More than running, cutting, jumping, changing direction. So at least in my mind, if you go straight to eccentrics, that's like going to the very hardest exercise first. And if you've ever worked with someone that has patellar tendinopathy, you'll probably know that that doesn't work well. And that's probably the reason why they had to have the pain at a 5 out of 10, simply because that's going to hurt a bunch. And I almost never start, unless someone is really mildly irritated, I almost never start with that single-legged squat on a slant board. That's just, I don't know. That's like putting a blowtorch straight on that patellar tendon from the beginning. So that might be one of the reasons why they didn't do quite as well. But one of the things I do a little bit more in my treatment now is that if someone is really irritable, I will consider more isometrics. And I usually will include isometrics at least in my warm-up for a few sets. And I have found that to be beneficial, although I'm not sure it's actually needed. But this study kind of changed my mind a little bit when I read through it. So I kind of alluded to this. There's a study by Baxter et al. I think it was 2023. But they basically went through all the most common rehab exercises for the Achilles tendon, and they just ranked them in terms of strain on the Achilles. So they did the same exact thing with the patellar tendon. Baxter was one of the authors, but the lead author was Rodrigo Scatone Silva. And this was in 2024. And essentially they used motion capture and force plate technology to rank exercises from easy to hard on the patellar tendon. And they use a combination of different kind of ways to measure this. So loading peak, rate, and impulse. So loading peak essentially is like how much total max strain is on the tendon during the exercise, right? The rate is how fast is that applied. We talked a little bit about that in the last podcast episode, link in the show notes. Generally speaking, the faster the rate is, the more strain or pain you're probably going to be placing on the tendon. And also impulse, right? So impulse is kind of how long is the force being applied. So if I do like a slow Spanish squat, I actually have a long impulse because I'm putting strain through that tendon for a longer period of time. Whereas if I do a jump, it's a quick impulse, right? It's kind of cool. They broke it down in these 3 different ways to quantify strain on the tendon. These were pain-free participants. So is this going to be exactly the same? Folks have pain? Who knows? I bet you it'd probably be less. These folks that have pain probably won't feel good loading the patellar tendon. So they may kind of stress shield by compensating, so on and so forth. So maybe not perfect, right? But pretty decent way of figuring out how much stress is going through the patellar tendon. And they looked at 35 different exercises. I'm not going to go super in depth into this just because I made a full video for it. I'll put a link in the show notes. You can check it out. But really briefly, they quantified strain on the patellar tendon into 3 different groups: tier 1, low stress; tier 2, moderate stress; and tier 3, high stress. Some of the things you saw in tier 1 were walking, low step up, 2-legged squats, partial range, and a low step down. In tier 2, they had exercises like a Bulgarian split squat, a full depth squat, a lunge, 2-leg forward hops, 2-leg forward hops maximally, a Spanish squat, running and stopping, 1-leg drop vertical jump. And then tier 3, this is the highest strain. You saw 1-leg maximal forward hop, 1-leg repeated forward hops, 1-leg counter movement jumps, running and cutting. And then the highest strain of any single movement that they studied, all 35 exercises, including all the jumping, including all the cutting, running, stopping, all that stuff, was the single leg squat on a decline slant board. So kind of my point earlier is that if you're starting your patients off with this exercise, you're starting them off with the most challenging movement we have studied to this point on the patellar tendon. So it just makes me laugh a little bit. Keep that in mind when you are dosing exercise. Again, I thought there's a really, really cool study. I made a whole video on it. So check that link in the show notes. Check it out. But yeah, you can use this study as a guideline for selecting movements. Any thought on this study before we move on, Kevin?
Yeah, I remember that Achilles tendon paper, but I didn't know that they came out with one for this. So I'll look more into that. I thought that's been really helpful. Just for kind of selecting like what's a early exercise I should focus on and then progressing. So yeah, good job by those authors. That's really cool.
Yeah, I mean, some of it's a little counterintuitive. Like I wouldn't have thought that's how how you would progress some of these exercises. But I mean, that's what our research is showing. So it kind of challenged my biases a little bit. The other thing is, I think it's probably even more useful for those post-op patients. Obviously, post-op Achilles, because there's more of them, but post-op patellar tendon kind of repairs, right? I think the other one they mentioned in the study was post-op Achilles reconstruction with a patellar tendon graft. You can use these exercises kind of dose from low to high when those stakes are going to be a little bit higher, right? So those post-op patients, is even more important that we dose appropriately. Whereas a non-op, we're a little less, conservative. We can be a little bit, I don't know, a little more aggressive with our exercise selection, but maybe not with those post-op patients. Movement modification. Should we change the way our athletes jump? This is one of the things I covered a little bit more in depth in my last literature review. And I tell you what, there's been more research that has come out over the course of time, and it's gotten even more confusing, Kevin. So that's always good, right? I took this quote from a study paper. Lead author was Harris, Jump Landing Mechanics and Patellar Tendinopathy in Elite Youth Basketballers. And one statement I think really rang true with what I was reading and learning too. And I'll just read it directly from the study. Despite the voluminous literature, so much volume there, a large number of participants, a multitude of investigated parameters, and consistent research focused on landing biomechanics, only a few associations can be identified, such as reduced ankle dorsiflexion or plantarflexion range. Further, the quality of the existing literature is inadequate to draw strong conclusions, with only 4 high-quality papers being found. We were unable to determine biomechanical factors that predicted patellar tendon pain onset, as longitudinal/prospective studies enabling causal interference are absent. What this essentially means is if you're jumping and landing in a more quad dominant fashion, so when you land, you're basically kind of bringing the knees forward, flexing the knees more. Thought is maybe that's going to lead to more patellar tendon pain. Maybe we should be altering people's jumping and landing mechanics in order to reduce people getting patellar tendon pain in the future, or modifying that movement so that we can help to rehab them. I still think this is an interesting treatment idea, and we are always modifying movement in the gym to try to progress athletes. So one of the things you can do is retrain jumping, so have them land with their hips back, get a little more hip flexion on the landing as opposed to more knee flexion. And this may be a modification that helps with pain, but doesn't seem like there's a causal relationship in the literature overall. In some of the papers, you'll find that, some not so much. So a little confusing, but I think you see the same thing with like gait, like running gait. Does that lead to patellofemoral pain? Does that lead to IT band pain? Some studies show maybe yes, some maybe not. It's all over the place, so it's complicated. I recommend you read through some of this literature yourself if you can. Again, link in the show notes for all the references. But for patellar tendon pain, doesn't seem like it's a strong risk factor. Any thoughts on that, Kevin? Did you find anything different?
Yeah, I think what I use that type of information for is just understanding that there's probably no perfect way to land to reduce these stresses. But, you do see, like, I think you see those more bouncy quad dominant athletes. Maybe they do have reduced ankle dorsiflexion, and the onset of pain is kind of related to how much knee flexion they're using as they're loading their quad. But then what I tend to see when it's really flared up is that they'll jump or step off a box, and they're really using a hip dominant strategy to avoid loading the knee once it's painful. And then, we do want to work on the mechanics a little bit, because I think this is just my opinion. I think their brain changes a little, and they get used to jumping with this hip dominant strategy or landing with this hip dominant strategy because of the pain they're having. And based on the amount of time they're doing that, it becomes their like new norm. So I look at it more from a performance standpoint. Is like, maybe they can optimize the way that they're landing. But we don't think about it as like, this is the avatar of the perfect landing mechanics. And, this is why you're having knee pain. But for the person in front of you, if you do feel like it's something that they're modifying because of the pain that they're having, it should be part of the treatment program to help them get back to the way they were, and maybe improve that if it's going to improve performance, is how I'll think about it.
Mm-hmm. And I think we talked about this a decent amount, and a little spoiler alert, because I just went through the literature on IT band, and we'll talk about the next podcast, right? Crazy. But one of the things you see quite a bit, and we went over this with patellofemoral pain, but when someone tries to do a step down task, they'll try to move more through the hip because the knee hurts, right? You used to think that, okay, you move through the hip, that's why you have knee pain. Now we're kind of finding, well, people probably move more through the hip because their knee hurts, right? And they're trying to use the hip a little bit more. You see that with patellar tendon pain, just like you're saying, Kevin, and an IT band pain. What happens with folks from that standpoint is as they progress into the run further and further, they generally run with a little less hip adduction. So the idea is that as they run further and that knee becomes a little more painful, they may actually run in a way to shield stress on that area. They limp, right? They're kind of limping. I call it limping. They're compensating. That makes sense. So movement changes due to pain. I think that's important. The physical therapists keep that in mind. It's not as simple as like, oh, the reason why you hurt is because you move this way. It's like, well, they might just move really differently because now they have pain. And maybe it was the way they moved before too. I think there's some relevance to that, but it's not the only piece of the puzzle. There's a lot of players there. So, and next, we already talked about this a little bit, but load management is going to be one way of helping to treat these folks. And in the progressive tendon loading paper, they use a pain monitoring model, which we've talked about extensively on this channel. In the pain monitoring model, essentially you can use all exercises that are 4 out of 10 or less. At least in this paper, for the progressive tendon loading, they use a 3 out of 10 as their kind of cutoff. And with the eccentrics group, it was 5 out of 10. And I don't know why. We should probably talk to the authors at some point, but maybe it's because single-legged decline squats are just painful, right? Also, they recommended modification of all athletic activities, right? Essentially, they cause greater than those numbers of pain. And they are also forced to either significantly reduce or avoid certain activities for at least 4 weeks at the start of rehab. So essentially, you continue all your sport activities within the limits of the acceptable pain parameters. And like I said, for the progressive tendon loading group, if you were doing your sport activities and it was less than a 3 out of 10 on a 0 to 10 scale, next day you're kind of back to your baseline, that's acceptable. So you can give your patient some guidance on which activities are okay and which ones to potentially avoid early on in therapy. Any thoughts on that before we move on, Kevin?
No, we can progress there.
Yeah, I think we've kind of beaten that dead horse. We hate animals, huh? I mean, if anything you learned,
Yeah, a lot of
listening to this
animal
podcast.
abuse on this podcast. Yep.
I love animals, but I love those analogies. All right. How about additional treatments? We know that this is a recalcitrant condition in a lot of individuals. It's tough to treat. Can we have an effect? Yes. But are outcomes phenomenal? Not really. In that progressive tendon loading, even with the better treatment, we had a 43% success rate getting back to the level of prior injury, right? So are there other additional treatments that we can try other than just exercise? This study here was in the Journal of Bone and Joint Surgery 2022, and it was entitled Patellar Tendinopathy Critical Analysis Review of Current Non-Operative Treatments. And essentially, they graded different treatments on basically an A to Z scale. I don't think it went all the way to Z, but A is good, and then B, C obviously is worse and worse. And essentially, exercise was at the top, grade A evidence to show that it is an effective treatment for folks that have patellar tendinopathy. However, PRP injections had a grade B, and they can be beneficial for refractory cases. So essentially, those folks that tend not to do really well with exercise, maybe a PRP injection is the next step. There's also a bit of evidence for stem cell treatments, either bone marrow or mesenchymal stem cells. There's a grade C evidence, so not as many high quality papers, and a little bit of evidence about hyaluronic injections having short-term effects. In terms of low-level laser, we actually use a high-powered laser at our clinic. I actually think it is pretty helpful for a lot of different tendon problems. There's insufficient or conflicting evidence for this. How about extracorporeal shockwave therapy for patellar tendinopathy? I tend to use a decent amount. Seems like the evidence is insufficient or conflicting, although I'll still give it a shot. Topical glycerol trinitrate. I didn't know much about this. I've never used it. They had grade 1 evidence for this. It stimulates healing. It's just something that goes over the patellar tendon. And the idea is that it stimulates a bit of healing. Never used it, but maybe an option to send it back to the physician. Hopefully they have an idea. Strapping. How about that patellar tendon strap that goes over the patellar tendon around the knee? So in the short term, can have a 25% reduction in pain, although it seems like there's no long-term benefit, right? And that kind of makes sense. We're not really changing the tendon structure or helping to heal that tendon, but it does seem to help with pain. And for a lot of folks early on, I'll say, yeah, give it a shot. If it works, keep using it, right? But it's probably not going to be that long-term solution. How about surgery? I think Lenny actually has a bilateral patellar tendon debridement patient right now. He seems to be doing pretty well. But what does the evidence show? Is it beneficial to get surgery if all these treatments fail? Yes, actually. It seems to be beneficial for refractory cases. Surgical intervention is considered after failure of non-operative treatments and typically occurs in tears greater than 50% of the tendon thickness and in tendons with increased tendon thickness, greater than 8.8 millimeters. So essentially, you're only doing this in patients that have either a pretty decent sized tear in the patellar tendon or a lot of tendinosis. And they actually have good return to sport rates. So that was actually pretty dang nice to see that if your patient's not doing well, obviously these are recalcitrant, you can consider surgery, and they actually tend to do pretty well. And I don't see too many of these, but again, Lenny has one right now. He seems to be doing well, and he's actually a pro hockey player, I believe. So you do see these, and they tend to do pretty dang well. What are your thoughts there, Kevin? Are you doing trinitral glycerate, rubbing it all over that knee?
No, but I'm going to. It's going to be the triglycerate guy. Is that what it is? Yeah. Yeah, I think it's, we're kind of spoiled where we work. We have access to some of those things, and we're doing the grade A stuff anyway. So then, why not try some of these things if it seems like they might offer some benefit, if there's some conflicting evidence, where our patients are there for a certain amount of time. So, they can spend as much time as they want with us. So we can really try a bunch of things and see if it helps. But, obviously you want to start with that grade A and give that an honest shot for quite a while. I have a lady right now with a hamstring tendinopathy that's been going on for, probably 2 years or so. And, she's at the point where she had a recent flare up, kind of fed up. So we're referring her to one of our local biologics doctors. And, I think that consult could be very helpful for her. So I think if you've reached a point where the patient feels like they've really, and she's been so compliant, she does a good job, and then little things kind of set her back still. So, she's kind of at her wit's end and just looking for another treatment option. So, I think eventually, when you are beating a dead horse for so long, it is okay to try other things. We have some options here to try. And I will say, anecdotally as well, I think the strap I've seen some benefit with, like, people will say, hey, I bought this strap. Should I try it? And usually what I do is have them put it on and we'll try some exercises. And if they're like, whoa, that feels better, then yeah, totally wear it. That's fine. If we can get more loading with the strap on, you feel better doing some of your activities with it on, or you're in season, you could play because you're wearing it, then yeah, it's totally worth it. I think just be honest that it's not going to solve the issue long term, but if they want to try it, definitely try it. So that's kind of how I look at that.
Yeah, for sure. And I think just like anything else, if you're not making progress, you probably should refer back to a doc. You just have to have a doc that's good, that knows about these additional treatments, stays on top of literature, maybe is a little more open-minded to some of the newer research coming out. I've been surprised sometimes. I have patients that have pretty stubborn tendinopathies. They end up going back to the doctor. Turns out they had a calcific tendinopathy, which is a little more recalcitrant sometimes. And they do something like a 10X procedure, and the patient does really, really well. And I wouldn't have known that unless we sent to a doc to get some additional imaging and figure out those next steps. So because it's tendinopathy, doesn't necessarily mean that you have no other options besides just exercise, which I think is sometimes the thought for physical therapists. I would say if you're not already, try to find a good physiatrist, someone who kind of specializes in things like orthobiologics, shockwave therapies, ancillary treatments, and then obviously a good surgeon as well, just because that's another good option if patients aren't progressing over the course of time. So, all right. So now you know all the basics about the evidence when it comes to patellar tendinopathy, but you still have no idea which exercises to choose for your patients. We just talked about how it's important to dose exercises, and I have a video that's going to show you exactly how, and it lives above Kevin's head. So Kevin, where's your head at? There it is. Go ahead and click on that link, and I'll go over how to dose exercises for patients that have patellar tendinopathy, so you don't flare them up and you give them enough stress so they get back to the sport and they love you. Click on that link and I'll see you there.